Hello to everybody, and welcome to this EANS webinar on AVM treatment. AVM, as you know, are very complex lesions, and their treatment requires knowledge of the pathology, of the vascular angioarchitectures, and also of their relationship with the brain. And the involvement of eloquent areas poses formidable challenges for AVM treatment, either for radiosurgery, embolization, and surgery too. We have at present three treatment modalities that will be explained here in this webinar. The first one is the intravascular or endovascular treatment, radiosurgery, and surgery. Our colleagues will focus on the role of each of this kind of treatment. And I will invite Isil to share her knowledge and opinion about the treatment, the endovascular treatment with all of us. Thank you.
Thank you, Piero. Before I start, I would like to thank the organizers for their kind invitation. It's a great pleasure and honor to be in this panel, and I hope all the participants will enjoy it. Now, I'm a radiologist by background, and I'm a neuroradiologist, and I've been doing neurointervention for more than 25 years, actually. Now I'm going to my presentation before taking too long. Okay, I'm gonna talk on curative brain AVM management using endovascular means, and I'm gonna emphasize on our multi-plug flow control technique for this purpose. The intranidal onyx injection technique, the so-called prolonged repetitive reflux and push technique that we developed since 1998, actually created a different philosophy in the endovascular brain AVM management. This technique initially got a lot of criticism since a certain mindset change was needed, because it used to be pre-operative embolization or pre-radiosurgery embolization before then. But then it gained worldwide acceptance, and many workshops, we trained many physicians for this. It was radical and a curative approach comparable to surgery, and the treatment targets became to cure all grade 1 and 2 AVMs by embolization alone. And we could really start to treat the high-grade AVMs as well with this technique. Here are some old examples. I would say more than 20 years ago, we treated this occipital AVM, for example, which is a perfect candidate or a classical candidate for surgery. However, it's also a straightforward case for endovascular and very easy for endovascular. And we were able to cure it with embolization alone. Or this one, which I don't know if it can be operated or not, or if it challenges other techniques, but this patient had a previous rupture, and we were able to cure this patient with embolization as well with our technique even at those dates. These are the post-embolization MRI on this actually 2 years control on this patient, MRI, and 2 years control angiography to show the stable result. We were able to finish such AVMs as well in one session, grade 3, unruptured. We were patient enough to occlude such an AVM with one injection only. You see the diffusion MRI after complete closure, or in such a grade 4 AVM, we were able to obtain such a compact embolization, and the remaining was radiated. We also treated the accompanying associated flow-related aneurysm, and after gamma knife, we were able to provide a cure for this patient together with the radiosurgery. And we published our old series with non-detachable catheters in 2011 with a overall complete obliteration rate of 51% with a 1.4 mortality and 7.1 morbidity, better results in grade 1 and 2, and higher morbid mortality in 3 to 5, as one may expect. Background information, well, everybody knows about the natural history and what may increase the risk of bleeding. And Aruba definitely created a big turmoil in the area with reporting threefold increase in death and stroke in the intervention arm. However, it deserved very valid criticism with its selection bias, and the results cannot be generalized, etc. But Aruba also indicated the necessity to improve the endovascular technique and make it usable with increased average quality. It had been not for everyone, so it should be improved. And after the technique of slow repetitive reflux and push technique, there was additional technical evolution like transarterial with proximal occlusion or transvenous approach. And lastly, we ourselves developed transarterial multi-plug flow control technique, which basically creates a closed system for more effective embolization that I'm going to show several examples. We learned that an effective and safe nidal penetration is all about controlling the flow to and within the nidus. And for example, when we put a single microcatheter, it may go to the venous side early with the flow coming from the other pedicles. However, if we put several catheters to flow all the major pedicles, then we can avoid early venous migration as well as backflow to the other arterial pedicles. And we published our technique 2 years ago, although we have been using for a very long time. And actually, multi-plug flow control technique is to create a closed flow control system around the nidus. And 4D is an essential information for us. And with 4D, we can understand the AVM nidus much better. For example, in this one, in 3 major pedicles from the MCA, 3 balloon catheters were placed, so almost complete flow control. And with the flow control, we were able to cure this AVM in a session, and this is the post-treatment MRI. We always get an MRI after our treatment to check the parenchyma, because washout from other pedicles slows down or prevented. This technique lessens not only the embolic agent migrating to venous side, but also amount of reflux on microcats in the arterial side. So that we can occlude the vein or veins or feeding arteries at the closest proximity to the nidus, which reduces the risk of arterial ischemia and venous compromise. Basically, the workflow of the technique is very similar to microsurgical management: turn around, control the feeders, take down the nidus, and occlude the veins. So in our own practice, endovascular treatment is the first-line treatment for ruptured AVMs unless there's a need for hematoma evacuation. And in the unruptured AVMs, which carry increased risk for bleeding or are symptomatic, when cure is deemed possible, either alone or with additional therapies, or if we can provide any benefit in a targeted treatment, then we also do endovascular treatment. And 4D is definitely essential to evaluate the AVMs regarding the treatment indication at the beginning, and then for the treatment planning. In grade 1 and 2 and some selected grade 3 and 4s, multi-plug flow control technique offers single stage cure if we can control all the feeders, all meaning almost all, we should say, because even in angiography, 4D, whatever, we may not appreciate very small pedicles because of the flow preference. Anyway, this was a young patient, left-handed, had a previous hemorrhage, as you can understand from the MRI, and this AVM of grade 2 with the 4D, we can understand that, for example, there is a stenosis at the draining vein, major draining vein, and the other small 2 veins are actually joining the major draining vein. So venous flow control is very important for the safety. And we decided to put 2 catheters in the MCA pedicles and 2 other catheters in the PCA temporal pedicles. So simultaneously, we have 4 catheters at the same time to inject simultaneously for full flow control. And we were able to achieve such a compact nidus obliteration. Please note that the vein and the feeding arteries are occluded only at the vicinity. We didn't occlude the arteries all the way proximal or veins all the way distal, but only at the proximity with our closed system flow control. And we were able to cure, and you see the post treatment MRI, no damage to the parenchyma. And when you control angiography, stable occlusion, if we do the embolization properly, it stays stable. We know that. This patient we treated in our live course of WLNC to transmission to Barcelona. In this high flow AVM, grade 3, we put 4 catheters. So this may be this may seem intimidating, like 4 catheters, how are we going to control all of them? This technique certainly is not a one-man show and requires at least a second person. So you have to be a team for simultaneous multi-plug injection. But it gives you very good control. and with 4 catheters at a time, 3 in the MCA, 1 in the PCA temporal pedicles, we were able to finish this AVM, and 2 years control with the MRI as well. If the AVM is in a critical location, multi-plug flow control becomes even more important, so that we should not be refluxing to any critical artery, as in this one, the anterior choroidal artery, hypocampal small AVM with a big venous aneurysm with a surrounding edema. And we put 3 catheters at the same at a time, one from the temporal pedicle from the MCA, another one from the temporal pedicle of PCA, and another one from the anterior choroidal artery. Actually, that one is not only to penetrate the nidus from here, but in order to avoid inadvertent reflux to the anterior choroidal artery beyond the point of choroidal point, so that it could cause neurologic deficit. And in this case, we were able to cure this AVM, and these are the post-operative MRI. And in diffusion series, apart from this tiny dot, we didn't cause any harm to the parenchyma with our full flow control and the occluded AVM you see. And 2 years control, stable result, and shows the thrombosed venous aneurysm and no edema around anymore. Multi-plug technique does not necessarily offer all flow control during the simultaneous injection. After developing our strategy, we can occlude one pedicle before we start our multi-plug injection. For example, in this one, this was a grade 4 left parietal AVM, and having contribution from ACA, MCA, as well as posterior choroidal. And this posterior choroidal artery may cause problem during the injection if we did not have a control here. So we occluded this pedicle to start with. We decided to occlude this pedicle to start with. These are the 4D images. So we see the nidus, the feeders, the draining veins, all the structures at any time point from any angle. In this 4D, we can appreciate the intranidal aneurysms, the venous ectasia of the draining vein, everything. So it's like virtual dissection of the AVM. And after we did pedicle injection to create only flow, not nidal penetration for the purpose of nidal penetration, but to control the flow from the posterior choroidal, we stopped this, we pulled our microcatheter, and then put 3 catheters, one from the pericallosal and 2 others from the MCA pedicles, 2 with balloon, 1 is detachable tip, and we were able to create such a compact onyx cast. And this was the post-operative angiography. And this was the MRI, post-operative second day with significant edema, but no diffusion restriction, meaning no ischemia. This patient had a one-time seizure, but the edema resolved, and post-operative 6-week control, MR reveals complete resolution of the perineidal edema. And 1-year control, you see the stable occlusion. A bigger one, this patient was under follow-up for a long time, but the seizures started to be hardly controlled and having some walking difficulty as well. If the numbers of feeders are more than manageable for the simultaneous multi-plug injections, then we stage the treatment in order to reduce the number of feeders to be handled simultaneously. So it has recruitment from MCA, ACA, PCA, posterior meningeal, and from both middle meningeals. So these are the 4Ds again. Anterior choroidal had a contribution to the AVM as well. And on 4D, we realized that it has deep drainage, and it is not a grade 4, but 5. And in first session, we went for the high flow part, the MCA part, with 2 microcatheters to decrease the flow, to reduce the feeder number of feeders. Second session, the dural component, and also the anterior choroidal, which, as I told in the previous example, it is important to prevent any inadvertent occlusion of anterior choroidal proximally. So we went all the way distally and inject from here to control the flow, and also occlude some part of nidus from here too. And this was after 2 sessions remaining very little, but of course this is not good enough. And in the 3rd session, which was performed during the live transmission of last year workshop, and Saruhan actually did this session, and with 2 microcatheters. This one, because it was en passage, he occluded the pedicle distally after the en passage part to keep the distal normal parenchyma, and then after embolization, the AVM was cured and the patient woke up fine. There is definitely edema around the AVM, as you see here, and you see the diffusion weighted series to check if there is any damage, and 10-week control. Patient is intact. And also 10-week angio showed stable occlusion. And one last patient about multiplug, a young patient, 2 times intraventricular bleeding, had a previous embolization elsewhere, very limited embolization. Then gamma knife was performed, and 10 years passed, and then the treatment failed. The patient came back with severe headache, increased seizure attacks, and the angiography showed this AVM, a very big AVM. So it was not possible to handle all the pedicles at the same time. So with the 4D, we detected the intranidal aneurysms filling from the PCA temporal pedicles. So in the first session, we went for the PCA temporal pedicles. This is just to decrease the number of the feeders so that we can handle in 1 session. And even in the second session, we decided to put 3 catheters from the MCA, from the left ICA, 1 from ACA. So we should put here from the right side, come from right side, because there's not enough room for coming from the left side, and another catheter to the PCA. So we need triple accesses, and then 5 catheters at a time. We did the embolization, and this is the end result with this compact nidus obliteration and control MRI. So overall, our multiplug series till last year, so the last 1 year cases are not included in this data. Actually, there is a selection bias. 3/4 of the cases were grade 1 and 3s. And in those, we had complete closure. Overall, 92% complete closure in the entire series, with a mortality 1.4, morbidity 4.4, and only one patient is bigger, having MRS bigger than 2 in the 3 months control. 2 patients operated on for postoperative hemorrhage, for decompression. This patient, one of them showed very good progress and discharged hospital MRS2, ended up in MRS1. The other and one other patient died from ischemic complication of a thalamic AVM. If I had, I would like to very briefly mention transvenous embolization. In our practice, it's only complementary. We either use as a final move when necessary, or when the arterial access is not possible or bears more risk. In this ruptured kid, intraventricular bleeding, a small, very small AVM, the superior cerebral selective angiography showed that the arterial side, because of the normal branches, we cannot embolize. So we decided to come from the venous side to not to harm the patient. A balloon was placed to control the flow from the arterial side, but not injected. All the injection was done through the catheter placed into the draining vein, and we were able to cure this AVM, this tiny AVM, with no harm to the patient. And this is the 1-year control. Another patient, this was one of our ex-fellows' case. He called us and we treated this patient in his center, grade 4. They did embolization and then had gamma knife, but this grade 4 stayed still filling, and there is a aneurysm as well on the venous side. So the patient definitely needed treatment, and we decided to treat this patient by transvenous way, means, because there are unpassaged vessels from the pericallosal artery, which also goes to normal parenchyma distally. In order to avoid any parenchymal damage, we come from transvenous side, but to control the flow, we put the balloon catheter in the pericallosal artery so that we can stop the arterial flow. And also we did pressure cooker technique. We coiled the draining vein so that we can penetrate the nidus from the vein with the liquid. And this was the end result. We were able to cure the AVM, see the distal part of the pericallosal artery was filling in a retrograde fashion, no capillary defect, and the part giving the unpassaged vessels is occluded. And this is the end result. And you see the postoperative 24-hour MRI on this patient. So actually, we target to cure the AVM, but there are selected cases where we do targeted embolization, or we do embolization to reduce for adjunctive treatment. One example, a young woman bled from this thalamic AVM grade 4 in the last month of her pregnancy, referred to us for treatment after she gave birth, and had this AVM, and the 4D, we realized that it has that aneurysm arterial side, you see the super selective catheterization. Because of the venous aneurysm, the transvenous route is not suitable to finish this AVM via transvenous, and arterial side, we may have given the patient deficit, so partial embolization was performed to eliminate the part with aneurysm, as well as to reduce the AVM more. And after this stage, the patient was radiated, and 2 years after the gamma knife, we were able to provide a cure for this patient together. So my conclusion, cerebral AVM treatment should be reserved for dedicated teams. It is not something like you do one in a year or something. And the decision should be made case by case. It's a very heterogeneous disease. Cerebral DSA should be performed for every AVM patient for a thorough understanding of the AVM, preferably with a state-of-art equipment. Otherwise, it doesn't provide any information more than MRI. Embolization should serve for a purpose. If you give little something there, little something to another pedicle, it doesn't make any help. So curative embolization, or at least targeted embolization in the selected cases, may be beneficial for the patient. Otherwise, it is better not to do it. And a multi-plug nidal flow control technique created a substantial change in the AVM management, providing more controllable, therefore more safer and efficient curative management. But it is definitely a teamwork and requires a state-of-art equipment. Otherwise, it shouldn't be done. And I would like to invite you all to our coming live conference. Thank you again for your interest and patience.
Thank you very much, Isel, for this wonderful presentation and to share with us all these very interesting cases. And of course, for the fact that you remind to all of us that this is a very difficult job, and it should be done by very experienced person. And I think this is the same thing for radiosurgery and surgery. It's not something that we can do in hospital with a very little case load. Otherwise, we won't get enough experience to get these wonderful results. Just a reminder for the people that are listening this webinar, if they have questions for the presenters, please use the Q&A chat for writing down their questions. And now we will go to the radiosurgery side, and Yosa will illustrate us what radiosurgery can give us for arteriovenous malformation. Thank you.
Yes, thank you so much for this nice introduction. And I would like to start by thanking Hakan and Piero for inviting me and giving the presentation on the radiosurgical treatment of cerebral arteriovenous malformations. As Piero has already said, I'm Yosa Frisch. I'm from the Department of Neurosurgery at the Medical University of Vienna. And I've been doing radiosurgery for the last 10 years with a small detour at Mayo Clinic between 2014 and 15. And after these beautiful pictures that we have just seen from Isil, I'm very happy actually to start now. Here is my index, and I'd also like to start with just a few cases that I have been doing very recently, then talk about our own data, our very recent evaluation that we did on the radiosurgical and combined endovascular and radiosurgical treatment. We also have very recent data regarding conservative management of brain AVMs that I would like to share with you, and then compare them to our treatment-related data. So let me start with a case that I did, I think, 5 years ago. That's the typical case of an unruptured brain AVM. The young patient, early 20s, presented with a seizure. Then the workup showed this AVM, and as you can see here on the angiography and on the brain MRI, due to patient wish, this was actually treated. It was in the post-aruba area, and I did it in one go. You already see the pictures that you see here are already the planning MRI and the planning angiography. I always do the radiosurgical planning on angiography, MRI, and I also do a CAT scan for bone window CAT scan, just to fuse all the different available imaging data. I did it in one go with 20 gray on the 50% isodose line. And due to some patient-related factors, he didn't show up for 2 to 3 years follow-up. Then we actually call him, and then the brain MRI 2 years later, 2.5 years later, already showed obliteration, and we could verify that by an angiography 3.5 years later. So this was totally obliterated after one gamma knife treatment. That's now another case that might be up for discussions. So that's actually a ruptured AVM. As you can see here, thalamic, hypothalamic thalamic AVM, that young female patient, 28 years old, presented with loss of consciousness, was sent to the emergency department, and then directly to our neurosurgical ICU, got some EVDs in, then got more or less emergency embolization, embolization of the case. It couldn't be obliterated by embolization, and then after a month on the ICU and a few more weeks on the normal ward, we decided for radiosurgical treatment. And as you can see here on the right side, these are already planning sequences for the radiosurgical treatment. So this treatment was also done on the 50% isodose line with 19 gray, what I did. And now it's a very recent case. Actually, she just came to me a few weeks ago with a 2-year brain MRI follow-up. And according to the brain MRI, the AVM is already obliterated. So those are obviously two of the very nice cases that went very well. So to give now a little introduction, I think all of us, or many of us, will talk about the classification, the general classifications on AVM. Obviously, for all of us, it's important. It doesn't matter if embolization, radiosurgery, or surgery. Especially for surgery, Spätzler-Martin grades are is D classification, and it's divided between 1, 2, 3, 4, and 5. And then there was the Spätzler-Pons classification published that kind of combines the grade 1 and 2 to class A, the grade 3 to class B, and the grade 4 and 5 to class C. So why is this important? Because those classifications should already give us a hint on if to treat, how to treat, and what might be the possible complications. Obviously, I want to mention that for radiosurgery, there is there is a special, or there are their own classifications have been published, especially by the colleagues from the US. There is the modified radiosurgery-based AVM score, the so-called REBAS, and the VRAS that is actually should also help us to decide the possible complications, or if and how to treat a patient by radiosurgery. In this case, especially the Virginia radiosurgery AVM scale also already includes in the classification a predescent bleeding of the lesion. which is especially for the decision if you do radiosurgical treatment or not, is actually a very important factor. Okay, so which already brings me to the discussion. As I showed you, I specifically selected those two cases. There is a ruptured and an unruptured AVM. So of course, if you talk about the treatment of AVMs, it's a huge difference, as what already mentioned before in the talk, if you talk about the treatment of a ruptured or even unruptured AVM. If you talk about the management of unruptured AVMs, which is actually, I think, the most probably discussable topic, then there seems to be no real consensus. It totally depends on which type of literature you want to read, and you will find proof for more or less every possible treatment and treatment combination. But to put it into in a way of a consensus for unruptured brain AVMs, many papers, many reviews, many guidelines suggest that for the low grade, Spätzler-Martin 1-2, Spätzler-Pons grade A, microsurgery is most often the primary treatment of choice, but also radiosurgery. Then for the middle grades, Spätzler-Martin 3 or Spätzler-Pons B, there is radiosurgery and or embolization, or just embolization, as you might say now, Isil. And then for the very high grade AVMs, well, observation, best medical treatment, radiosurgery, embolization, a combination of both. However, the discussion how to treat an unruptured AVM actually took a real hit when the Aruba study was published almost 10 years ago now, because they don't even talk about how to treat. They actually wanted to tell us that medical management is superior to any form of treatment. Of course, as you know, or if you know anything about AVM treatment, or if you have anything to do with AVM patients in your daily practice, you know that there has been severe and many criticism regarding this Aruba study. However, it is still the only prospective randomized trial so far on AVM management, unruptured brain AVM management. And they concluded that medical management is superior. Of course, after in the so-called post-Aruba trial, this is like AC and BC. Now we talk about before and after Aruba in the treatment of unruptured brain AVMs. There have been many retrospective studies that show that in dedicated centers, specific treatment, of course, now I talk about radiosurgery data, there is a much much lower complication risk than proposed by the put together interventional arm of the Aruba study, and that patients may benefit severely from radiosurgical treatment. There is another example now of a very good paper from the colleagues at Mayo Clinic that also showed that, for example, the annual hemorrhage rate compared to what the Aruba study published in the best medical arm is 1.3% after first gamma knife treatment, and that selected patients benefit from radiosurgical treatment. Well, what I would like to show with you now is obviously we have also evaluated our own data. We have been doing radiosurgical treatment on AVMs since 1992 in our department. So we evaluated the Vienna series, all the patients that were referred to us and treated at our department between 1992 and 2018. This is part of the PhD work of my PhD student, Dorian Hirschmann. And to make a long story short, in the end, we could include 388 cases with a good, long enough outcome into our outcome analysis. And out of those, 223 were treated by radiosurgery alone, and 165 had a combined endovascular and radiosurgical treatment. What is actually important is that those are all the patients that have been radiosurgically treated at our department, meaning there were patients that had a hemorrhage prior to the or at the time of the presentation, and patients without hemorrhage. Obviously, the majority of patients who presented with a hemorrhage at the time of diagnosis were seen in the combined treatment arm, meaning they had embolization prior to their radiosurgical treatment. We included in this study AVMs of all Spätzle Pons and Spätzle Martin grades, and this was also obviously a very wide range of AVM size, AVM volume, and localizations all over the brain. Well, to show you here very quickly, that's like a typical, very nice AVM at the bottom, just to illustrate treatment planning, but to show the crude data. So you can see here that in the combined treatment arm, obviously the larger AVMs were located compared to the patients that were treated radiosurgically alone over the last 30 years. However, the way how those were treated radiosurgically is almost the same in both treatment groups. We mainly planned on the 50% isodose line, and we mainly prescribed between 18 and 20 gray, median 19 gray. So what we could see here now is that the obliteration rates are obviously significantly higher, or there's a lower, shorter median time to obliteration, the radiosurgery alone group compared to the combined group. However, this is also, there's a bias, because the patients that were treated in a combined way were obviously the more complex patients. However, there is a very high percentage of, obliteration rates. The obliteration per se is dependent on the Spätzle Martin or Spätzle Pons class. And as you can see here, in the three different, in this Kaplan-Meier graph, you cannot work nowadays without Kaplan-Meier graphs, obviously. You see that the fastest and the highest obliteration rates are in the low Spätzle Pons class A, followed by Spätzle Pons class B, and then obviously Spätzle Pons class C. So that's in the total sample. What is now very nice to see that in the gamma knife only treatment group, obviously the best results are found among Spätzle Pons class A and Spätzle Pons class B patients. And to be honest, in the Spätzle Pons class C, the obliteration rates are not that good. However, if you check that now in our combined radiosurgery and embolization group, you can see that if there are selected Spätzle Pons class C patients that undergo prior embolization and then targeted radiosurgical treatment, the obliteration rates actually align from the Spätzle Pons class C with the Spätzle Pons class B, and then at the end have actually very good obliteration rates. We obviously also evaluated the annual hemorrhage rate after gamma knives. So what I really want to mention is that this is after the first radiosurgical treatment. So the patient comes in, gets radiosurgical treatment, and then in the waiting time, in the time between until time to obliteration, or even in the time between the second planned stage gamma knife treatment, this is the hemorrhage rate of 1.3%. And obviously our patient group here of 400 brain AVM patient, as I showed you before, also includes complex cases. So there were actually a third of our patients who needed multiple radiosurgical treatments. It was very interesting that there was really no impact on the hemorrhage rate after the radiosurgical treatment, meaning the treatment group, or if there was a hemorrhage actually before the treatment. Complications, you always have to talk about complications if you talk about treatment. So the overall number of radiation-associated complication was 4.9%. Those includes clinically not symptomatic, only radiologically diagnosed complications as well. And those are already the long-term outcome data. So I'd like to conclude for this first part that I would like to wanted to share with you of our own data, that in our opinion, gamma knife radiosurgery is a highly effective treatment option for brain AVMs. Time to obliteration rates after radiosurgery depend on the Spätzle Pons class, but in my practice, or in my opinion, mainly on AVM size. And with treatment, as we have already heard before, in a dedicated tertiary referral center with a high caseload, we actually achieve very good obliteration rates with a very low annual hemorrhage risk after radiosurgery. And if you closely work together with your vascular colleagues, prior embolization reduces the time to obliteration, increases the obliteration rate of selected high-class brain AVMs. So we have talked about the Aruba trial already, and of course, after the Aruba trial, there were also not only like the typical retrospective data sets, but there was also very recently a very nice meta-analysis published that I would like to share with you. This is a meta-analysis that actually included more than 1,600 cases and compared those data of the radiosurgical treatment to the interventional arm of the Aruba study. So why do I mention it now? Because the conclusion was that our findings suggest that the results of the Aruba do not reflect the real-world safety and efficacy of stereotactic radiosurgery for unruptured brain AVMs. Okay, so far, obviously, I agree with that. However, as I've said before, the Aruba study is still the only prospective randomized trial. So we actually have to take that in consideration when counseling patients in my everyday practice. And this has been, to be honest, a problem for me for the last few years since the Aruba study had been published, and even since the follow-up study had been published in 2020. So when the follow-up study got published in 2020, I decided to perform another analysis of our data. And we could very recently publish that. So we decided to actually try to get data not only on our own treatment, but to compare those data to what actually Aruba study really evaluated, because the Aruba study evaluated not treatment. Yes, they evaluated treatment, but they actually evaluated the best medical management versus a combined treatment. So what we did is we looked at all our AVM patients that have ever been referred to our center, and a total number of 900 brain AVM patients had been referred to our hospital in the last 30 years. And of course, the majority of those patients had been treated or already presented with a ruptured brain AVM at the time of diagnosis and had to be treated because of that. However, 13% of those patients, of those 900, almost 900 patients, for some reasons had been managed conservatively. The majority of those patients had been managed conservatively because of patient wish. So we actually had the possibility to evaluate long-term outcome data of 107 patients with brain AVMs, unruptured brain AVMs, thus Aruba eligible, who had not been treated in any way. As you can see here, already this is a little bit already of outcome, because out of those 107 patients, 18 patients actually had a rupture during or in their observation period. 89% in the observation period did not present with a brain AVM hemorrhage. So those patients who actually presented with an hemorrhage after the initial diagnosis of an AVM amounted to 17%. The median time to AVM rupture, according to the Kaplan-Meier estimation, was almost 20 years. But the cumulative 1, 5, and 10-year hemorrhage rates were 3, 11, and 15%. And you can see here the Kaplan-Meier graph on the left, according to this median time to AVM rupture in this sample of conservatively managed brain AVMs. So just to share some very quick data with you, we did several Cox regression analysis and several risk factor analysis, and the only really risk factor that actually was evident here, statistically significant, was that deep and temporal localization among this sample was actually a significant risk factor for subsequent hemorrhage from those brain AVMs. The presence of seizures reached borderline significance. There was no influence on the hemorrhage rates of the Spetzler-Martin or Spetzler-Pons grades or class. So why do I share those data with you now? Because we obviously compared those data to the data that were presented in the Aruba medical management arm. So we had a similar number of patients with very, very similar baseline characteristics, more or less same median age, same percentage of female patients, same median MRS score. However, obviously, we had a much higher, much longer follow-up period. What is very interesting that at the time of last follow-up, the patients who actually presented with still a very good modified ranking scale score of 0-1 were almost the same in the Aruba and at our long-term follow-up. However, now the differences come. The annual hemorrhage rate was obviously higher, not much, but it was higher, the calculated annual hemorrhage rate in our observation period. However, the cumulative 5 and 10-year hemorrhage rates already rose up to 15% if you go for a long-term follow-up. And what was really the game changer for us, the Aruba in their short follow-up presented AVM-related mortality of 0. In this, so admittedly, somehow also biased sample, we had an 8% mortality, AVM-related mortality in the long-term follow-up. So what did we do next? Obviously, we compare those data of the conservative medical management to the outcome after radiosurgery. And we did not only compare it to our own data, but also to the meta-analysis and to different other data that had been published so far and in the so-called post-Aruba area. So what you can see here that after radiosurgery, the annual hemorrhage rates after the first radiosurgical treatment is published in the literature in our own data in the meta-analysis between 1.1 and 1.3, 1.4%. In the conservative medical management arm, in our study, in the Aruba study, is much higher. It's almost a double amount of annual hemorrhage risk. The mortality rate in different studies is between 1 and 2%, and in our own series, it's even below 1% after 2007, which we call the modern radiosurgical treatment era. It is 8% in the conservative long-term data. So I'd like to conclude now that taking all this data together, and I know this was a lot of data now, a lot of stats, in our opinion, in experienced hands, gamma knife radiosurgery is a highly efficient method even to treat brain AVMs. It is a very good treatment option as a standalone treatment, and in a multimodal treatment concept, always work together with your vascular colleagues. Even in the post-Aruba area, tailored active treatment options may be offered to patients with unruptured brain AVMs. I mean, there's no discussion, you have to treat a ruptured AVM. Individual risk factors obviously should be weighed against the center's treatment-specific risks. And there, I didn't have time to show or to talk about that too much, but multimodal or staged, and I talk about volume staged radiosurgery, even enables the treatment of selected large or high-class brain AVMs. And I would also like to share with you a case now that has been a treatment in progress that might also be open for discussion. I'm very interested about what the other colleagues or the audience is going to say to that case. That's the case that I've been just starting to treat. It's a boy, a 10-year-old boy that 2 years ago, when he was diagnosed with this not very nice AVM, the initial counsel, not only in our center, but before he was referred to us, actually was, due to the Aruba study, not to treat the boy in any form, in any way, not endovascular, not radiosurgery, nothing. And then he was referred to us, and then we started different workups. And at the initial time, due to the pre-counseling that the parents had, they also said, okay, no treatment. However, there was no hemorrhage, but the boy suffers from progressive neurological symptoms. And after many discussions, after long hours of counseling, the decision was made to treat the patient by radiosurgery, and I've just performed the first treatment a month ago. So I'm going to be very happy probably in the next webinar in 1 or 2 years to share those outcome data with you. And to conclude with this case, never forget that we're actually talking about individual patients here when we talk about all the stats that we present. Thanks for your attention, and I'm open for any discussion, any questions later on. Thank you so much.
Thank you very much for your presentation and for the very good analysis of the data that are in the literature, and they support the use of radiosurgery or any form of treatment to treat the AVM, which is something that we have on what we have work on for several years after the Aruba trial that at a certain point have stopped the neurosurgery of neurosurgery, endovascular, and radiosurgery of AVM. Thank you very much for your presentation. And now we will go to the Marco Censato presentation on surgery, which is the other main modalities of AVM treatment.
Hello, you see my screen? You see it? Okay. Do you hear me? May I go? Piero, mi senti?
It's okay. Please go on.
Okay.
Everything's okay.
Well, we have heard several two very interesting discussion, and I think that both of the fields in treatment and AVM are very important. So we have the lucky condition to have both and a very good endovascular team, where everybody of you, I think, knows Boccardi, and we have a very good Gamma Knife team, and we have a good neurosurgical team. So we see many AVMs, and always we discuss the treatment in the three modalities together. From a surgical point of view, there is no doubt that a ruptured AVM has to be treated, but as we all discussed and we all know, indication for treatment for unruptured AVM balance between two different way of thinking, let them leave without harming them, or do something to prevent the future damage due to the rupture of the AVM. Of course, with this was a disaster. The Aruba trial that has been considered in the previous talk, and for us, from a surgical point of view, we have plenty of papers and publication against this study, and I think that we all think that we don't still have to think this as a reference, because although it's an unblinded, multi-center randomized trial, the design of the treatment of this study was really biased, and there is no doubt that this problem to put all the kind of treatment together was a big mess. So we published a few years later, after the Aruba trial, a consensus conference on unruptured AVM, where we all together, we had a surgical team, endovascular team, and international radiosurgical team, and we stated together that at least grade 1 and 2 has to be treated, while higher grade has to be treated based on case to case. These are what we have done in these last 11 years, 20 years, 12 years. As you see here, we had the Aruba trial, and so we had, of course, as everybody, a diminishing of the AVM treated, but then AVM returned to be treated, and now we deal and we treated more or less more than 90 patients a year. As you see here, Gamma Knife has a great role but also surgery has it, while endovascular treatment is still very low in as a cure and a definite treatment of AVM. This is my personal series from a surgical point of view. As you see here, unruptured still are the main important. We propose treatment for unruptured AVM, although Gamma Knife, although Aruba stated the contrary, but in our opinion, and this is a paper we published a few years ago, 5-6 years ago, where we put together we compare the outcome from a surgical treated AVM, ruptured and unruptured. And what we have to consider is that all the unruptured AVM have been treated. But as you see here, if you treat an AVM surgically, if you treat an AVM after rupture, more than almost 1/3 of the patient has a deficit, is disabled after treatment. So the importance of rupture in the outcome of the AVM is very high, much more important than the impact of surgery by itself. You see, if you treat an AVM unruptured and well studied, well prepared, well evaluated, and of course, Spezza and Pons A+B, and of course, not considering 4 and 5 grade, the outcome is very good with a very low morbidity and mortality. So considering the fact that the average rate of rupture accepted by most of the study, if you consider that 2% a year is the average considering rate of rupture, after 20 years out of 100 patients, you will have 33 patients that has bled. But after bleeding, 1/3 of them will have a permanent deficit with an MRI greater than 1. So out of 100, 12 patients will be with a permanent deficit. If you treat them before rupture, we will have a permanent deficit of 4.25 in more or less. So the two curves cross around 6.5 years. So if you have a life expectancy more than 6.5 years, we think that preventive treatment is worthwhile. Because as you know, this is our data, most of them ruptured around the age of 40, between 40 and 30 and 40 years of age. So in the fourth decade, the risk of rupture is higher than in the other. So if you have a young patient, our proposal is to treat an AVM. But of course, surgery requires judicial selection, and it's based on what? Of course, and I think we all agree, eloquence is the main problem. But if you consider also size and deep feeders, at the end are still a problem with eloquence, because size means the involvement of the deep white matter, and so this is eloquent also. So the size itself is not a problem. It's something that bring you in a white matter, deep white matter, which is eloquent. So as we know, cortical eloquent area will be spared by surgical treatment, And for this reason, we have to do a careful preoperative selection and avoid clearly eloquent area with a functional MRI, DTI, and whatever you think. But then alternative are, of course, as I think you all agree, gamma knife. But also white matter is eloquent part of the brain, and until a decade ago there was not much attention, at least from a surgical point of view, of white matter. And in many cases we as a surgeon we decide to treat an AVM, and then we found deep medullary feeders that has to be followed in the deep of the white matter because they were very difficult to treat. And so we often went out of what we were programmed before surgery. And so following these medullary deep feeders, we enter in eloquent white matter, and this was the main reason of having a deficit after surgery, because these are technically difficult. They are most responsible for postoperative hemorrhage, and moreover, you need to follow them deep in the white matter, not allowing you to stop where you want to stop. And so the problem of dealing with these vessels is mainly hemostasis, but as we all know, in the last decades, there was a high and very important evolution on endovascular devices. We had coil, we had the web, we have flow diversion, we have every year a new device. Also in surgery, we had a new device in the last 10, 15 years that gave us a very different instrument to treat, to deal with hemostasis of this vessel. We had a selective pre-surgical embo, selective per-surgical embo. Mainly, we had the introduction of non-stitch bipolar, which are much more effective than before in coagulating this vessel. We can coagulate this vessel in a dry fashion without irrigating, and which is much more effective. We have different techniques, but having new instrument, we can treat an AVM more similar to a tumor, so we can surround the AVM without entering in a deep white matter without control. So we can have a much more selective resection without damaging the adjacent white matter. And this is the reason why, at least in low-grade AVM, we have a very good result at the end. Selective and endovascular preoperative treatment of AVM for us is something we suggest as just something we require to close, we require to the endovascular team to occlude vessels which are not reachable from a surgical point of view, and we try to avoid an unplanned treatment to embolize an AVM and then send it to surgeon, as in this case. This was an AVM that came to us after a somehow nidal embolization that was a problem, because we, as a surgeon, we found a big bulk of onyx and then all the vessel behind it. So in a case like this, the embolization was not useful and complicated surgery. So what we require in an AVM like this one, this is similar, is embolize for surgery, occlude this vessel that was here, this vessel which is behind the AVM, and then all these vessels can be controlled easily by surgery. So, moreover, embolization with onyx often is done by big vessels that come from the surface, which can be controlled by surgery, and in many cases leave these deep white vessels untouched, and so these vessels after embolization increase in size. And so when you arrive in surgery, these vessels are more complex than they were before. So the advantage of closing this, that you can close with the surgical treatment is not useful. So when we ask for endovascular preoperative embolization, we ask to close this vessel, not these vessels, and not the nidus. Because often we also have that we can, the embolization of the nidus with onyx is something that can increase the volume of the nidus. This is the same zoom of the image, and you can see here that an AVM like this double his size with the onyx without any advantage because it was not closed. So in many cases, we think that endovascular, of course, the multi-plug needle flow control technique could be a good option, and in many cases, as normally is done elsewhere and everywhere, endovascular treatment is not useful for surgery unless you occlude deep vessel, difficult to treat by surgery in the beginning part of the surgery. What is important to show, and I want to show you, we all know that how these fragile vessels, these are the so-called red devil, the very tiny vessel, very fragile, and the white matter, and they're very difficult to close by surgery. But the introduction also of laser is a very nice instrument to occlude them without touching and without stitching with the bipolar, and you can close them very effectively with laser. Another important thing besides eloquence, and I want to stress the importance of white matter as an eloquence, and you have to consider it, is the venous pattern. The deep vein often are expression of deep feeders, but they are more responsible of the surgical complication that they can thrombose with unpredictable consequence. I want to show you the case of this plastic surgeon that had this AVM. The nidus itself is not such a big deal. It's not eloquent, and so we consider focusing on the nidus itself, we consider it surgical. Then we operated, we took it out, no immediate problem, but this was a CT scan on day 1. But if you see it in the day 2, and then day 3, and then day 5, you can see that we had an edema and a shift of the midline that at the end bring us to decompressive craniotomy, and until then we had a new the brain decreased in size, and then at the end the patient got discharged. But the patient then we put again the bone, and the patient at the end went well, and he is still a plastic surgeon, and he still works, so without problem at distance. But this was a problem due to the the extension of the thrombose of the vein that were also used by the brain, and this was underestimated before surgery. So we think that dealing with the vein is very important. It's something we have to consider for surgery. This was another important another patient with a deep, huge AVM that had this big drainage vein in deep in the brain, and with all those ectasias that were very dangerous, a patient bled. But surgery in a case like this was very scareful. And so we did the first embolization, trying to reduce the size of the AVM, but not occluding it. The goal was to reduce the venous size. So we waited a while and then reduce also the second embolization to reduce the venous size until 2 months after the vein was this size. And then on this side, we went for surgery, and this was the outcome without any complication. And the patient went fine with the MRS of the 0 without any deficit. So the importance of vein is something we have to consider. And also gamma knife is a very useful instrument. You see here, this is polar temporal AVM, which is by itself, as you see here, the nidus is small, is temporal, right temporal, not particularly difficult. But if you see the venous involvement of this patient, this is extremely scary. So we send the patient to gamma knife, and then we wait for what's going on. So what we want to stress is that when you have to consider a treatment of a patient, you have to plan what you are going to do. So the risk is something to do. It's important to consider invasive and not invasive treatment, and not try to save the patient from the surgeon, just having a non-invasive treatment without a definite plan. So I want to show you this patient. This patient is this patient was a 45 young man that had 8 embolization over 20 years, then 2 gamma knife treatment. And after 8 embolization, 2 gamma knife treatment, the AVM was not occluded. But what happened is an AVM like this, of course, is a scary AVM, is an AVM, eloquent AVM. But what happened that after that is he developed a huge edema one year after the last gamma knife, and because of the summatory effect of the 8 endovascular patent plus 2 gamma knife, at the end he had a radionecrosis that evolved in a very problematic symptoms, and the patient that was not paretic, at the end he was hemiparetic, severely hemiparetic. And so at the end we decided to go for surgery. We took it out, and as you see here, at the end the edema reduced because we took out the cause of the radiosurgery. This was before. So it's important to plan a strategy, to plan a treatment, and where surgery can be the end of the treatment. This is another huge AVM in a young lady that was preoperatively reduced. This is, you see that here you had a very large vein in the ventricle. The goal was an endovascular session to, there was an aneurysm that was closed, but then we had a first endovascular session to reduce it, and then a second endovascular session to take out this component coming from the posterior circulation. And then at the end, this was before surgery, and then she went for surgery with at the end a complete obliteration without any problem. So what we want to stress, and this is what we stressed in the European Consensus Conference, is that if a treatment is indicated, the primary status should be defined by a multidisciplinary team prior to the beginning of any kind of treatment you want to start. Also here, there is an important topic that I think it will be interesting in the future, and we still have a few data about that. Radiosurgery can be very useful also for downgrading. We did several of them like this. This was a large AVM, by itself not eloquent because it was posterior parietal, and we did a gamma knife that reduced the size, and then we went for surgery. Also this one downgrading, then this was result, and then this was we went for surgery. This was another case that with the diffuse AVM that was difficult to control from a surgical point, that we thought it could be difficult for surgery, and then we did two gamma knife on two different area, on mainly on the venous side. So I think it's important also to consider if which kind of stage of the radiosurgery, and because we are in a session of radiosurgery, I think that radiosurgery has to be considered as an option for downgrading, and we have to consider which kind of downgrading we should consider for eventually surgery. We had few of them, mostly for there was an effective gamma knife treatment rather than a planned downgrading. But now we started with an intentional downgrading. We have quite a few patients that were planned for surgery in the future. So we have to, the goal is downgrade the AVM and then bring it to surgery in a future time. Concerning gamma knife by itself, we think that gamma knife is good. It's of course is a very valuable instrument in our hands, but you have to consider that these are some data we have to consider, and this is, I think it's not very different from what I have seen from the previous speech, that there is a high rate of effective treatment. So when you have a Spätzle and Pons A, in our opinion, surgery remain the main treatment, and although there is a small AVM, but when it's superficial, in our opinion, surgery remain the main important the main effective treatment, rather than gamma knife. Of course, gamma knife is very useful for deep, eloquent, and higher risk surgically, from a surgical point of view, AVM, but considering also in our experience, the results are lower than the result of AVM. So for small AVMs, surgery remained the best treatment. And And that's it. Thank you.
Thank you, Marco, for this presentation and for sharing with us your strategy in treating AVM and your advice on which AVM surgery should be applied. I think that there is a lot of material for another webinar, especially on big AVM, where surgery has its limit, radiosurgery has limits too, and embolization is not the ideal treatment too. Maybe in this case, a combination of different techniques could lead to the solution, or as you have shown, I mean, the previous irradiation will lead to a downgrading of the AVM, and then some of also big and not surgical AVM could become surgical and eventually treated. I think that we have some question from the audience, and I would like that Hakan would take control of the questions of from the audience. Thank you, Hakan. Can you just go to the question and answer, and sharing the question with our presenters?
First, thanks a lot for all presenters. I think this is a successful webinar because we start with over 100 participants and we are still alive with them. So I'm starting with the first question. What is the advantage of the surgical management of complex AVMs with hybrid operating technique in comparison to embolization? I think Marco can answer this question.
Well, it's difficult to say. We don't have an hybrid operating room, and we are waiting for we asked it, and we are planning to build it in a hopefully within a year or two at least, because we think that hybrid is very difficult to consider hybrid an hybrid treatment in the same setting. For sure, it's very important to have a control, and after surgery you need to have a geographic control after surgery. And so now we have to close the patient, go to the angiography, and then eventually come back to surgery if there is a residual, because it's very important to check if there is a residual. In a few cases, could be an advantage to have an occlusion, but I think that doing the same operation in the meantime, I don't know if there is a great advantage. From our point of view, I think that and unless you consider this multi-plug needle flow control technique, which can be promising, which is, in my opinion, at least in the previous and in a single technique, endovascular technique, there is a very high risk of not complete obliteration. Of course, you can close in a normal fashion. You can close 60% or more of the AVM, but in the remaining 40%, you increase the risk of rebleeding afterwards. So you change something that can be dangerous. So if you want, I don't know exactly what you mean with this question, but if you want to compare surgery and endovascular from from a classical point of view, I stress that the fact that multi-plug nidal flow control technique can be different than the classical endovascular treatment, but in a normal, and everyone does around the world, the risk of endovascular treatment is higher, and this is also the reason why Aruba had those results, but because most of the cases of Aruba were incomplete endovascular treatment and not surgical treatment, and why surgery has a much lower, for the reason I show, complication than it used to have. So, in my opinion, I'm not sure that an hybrid operating technique to get joined in the single room and in the single time can be a great advantage, maybe in sometimes, but mainly to check or to find if there is a residual. I don't know what you think, Aysel.
May I, Hakan?
Yes, please.
Okay.
I'm
Actually,
waiting for your response.
I agree with Marco 100% that if you do a partial embolization with no plan and you just embolize the easier feeder or whatever, it doesn't make any help to anyone. But if you do partial embolization for a plan, then it may help. For example, if you reduce the size, and the reduced size may increase the closure with gamma knife, for example, then you make a service for the patient. Otherwise, I mean, just doing embolization would not make any help. This is my thought, and no need to increase the risk of the patient. If the surgeon can operate on without our help, then go ahead and operate. But most of the time, not all surgeons are qualified as well. So we have to admit that too. I mean, not only the neurointervention, all neurointerventionists are experts or qualified. Also, many of the surgeons are not experienced in AVM surgery as well. Coming back to the hybrid, I do not have any, we don't have the hybrid system anyway, but to my thinking, if the embolization is not complete, then embolizing and then having the surgery done might be good for the coronaries of the neurointerventionist, because then you don't need to worry about post-embolization hemorrhage. And you do it in a single shot, I would say. So it may be good for the patient if the embolization is a planned embolization to be followed by surgery. Regarding the partial embolization, the most dreadful thing is compromising the venous side. If you embolize and increase the risk of the remaining, then you do not good, but you do bad. So staged embolization should be done in a way that you do not increase the risk. I mean, you shouldn't take any, risk to compromise the venous flow.
Yeah.
I don't know if this makes any sense.
Yeah, I agree with you. May I just say another thing? You said that there are not all the surgeons are good for AVM, but this, in my opinion, is not a reason that any endovascular try to embolize an AVM, because it's a complex pathology and has to be treated in a center where you have a good endovascular and good surgeon. So I think that there is no excuse for an endovascular to say, I did something because I don't have a surgeon. I think that if you don't have a surgeon, send it to a place where you have a surgeon, because there is no excuse anymore for that. I think that we as a surgeon we have to compare with the masters, so we cannot do something because we decide to do something. And the endovascular is not anymore a pioneer field. You have to compare with the master to do what is good for the patient. Is not anymore a pioneering field when you can do whatever you want without any rule, just because you don't have a surgeon or you don't have a center where can be treated. So I think that AVM rarely are an emergent treatment, very rarely. So I think that you have to send it to a center where they can treat it in a 360% 360 degrees fashion. I don't know if
I cannot agree more. Actually, this was my conclusion slide, that AVMs should be treated by the dedicated groups, not, you do if it's once in a year, once in a two cases in a year. I cannot agree more. That's for sure. I'm not saying that you can embolize because you don't have a surgeon, but I do embolize because I do it good. And I have good results, and I do embolize if I feel I can have a benefit for the patient, which means in the majority, for the cure of the patient. If I feel that I cannot finish an AVM, then it should at least serve for a purpose. Hakan knows our cases because he's the one. Most of our, not finished cases referred to, how you embolize is also important. I know you are lucky as well, Marco, because Bucardi and his team is very well known group in our field, but we are also very, very good in our field and very well known. And we held many workshops, including many people coming from Italy as well to be trained. So I cannot agree more with you that the treatment should be performed by the experienced people. It is not a, try and do thing anymore. It may be 30 years ago, but not anymore. That I definitely 100% agree. And may I have a statement just to congratulate Yoza for one thing. I mean, I have to say this. Is it okay, moderators?
Yeah, of course. Actually,
or we can continue with the questions, no problem. I can tell it.
Actually, we won't have too much time. I'll make a conclusion, but you really, both of you give definite and important messages, and I will repeat at the end. And what are the risks of choosing staged EMBO, Dr. Seitchin asked? For the Dr. Saatchi, what are the risks of choosing staged embolization?
Actually, we discussed in the previous part as well. If you are staging, there is the risk of having a venous compromise, which may induce hemorrhage. So if you are actually in our multi-plug technique, when we prefer staged treatment, it is to decrease the number of pedicles which can be handled in one, simultaneously at a time, one time, not to finish the AVM. We do not push in the initial stages, I would say. That's one thing. It is not, to decrease the AVM that much, but to decrease the number of pedicles to be handled. And you have to start with the higher risk part, which could be the part with the higher flow, or the part including intranidal aneurysms, for example. So it should be planned. That's where the 4D has a great contribution, because you can understand the nidus better than your 3D or 2D angiography. So it's very important to see where is venous stenosis, where is intranidal aneurysm, etc., so that you will take lesser risk when you stage the embolization.
And Dr. Bayramov, about your question, I think I should answer this, and we have to talk on this question case by case. There is no best management for any ruptured AVM in brainstem or somewhere else. We have to decide case by case. So again, Dr. Shirin asked, I think this question is for the YOSA about their series, about her series. How did you decide on either only gamma knife or gamma knife plus embo?
Yeah, I think this relates to the data that I presented. Well, this is a retrospective analysis on over 30 years. So this is over 500 patients, actually, and 400 in the follow-up. So in the pre-modern era, as we called it, I mean, there were also patients that, for example, as Isil already mentioned, without, or Marco, I agree with both of you, you have to have a definite plan. However, as we know, it has been very often, especially in the early days of endovascular and radiosurgical and even surgical treatment of AVMs, that there was a 1, 2, 3, 4 attempts of prior embolization, and then it didn't work. And then the gamma knife department the gamma knife unit in our department got them. So for this retrospective data that I presented, there wasn't always the predefined plan that we actually wanted, because very often it didn't work, the embolization didn't work, and then we got it. However, in the modern era and how we have been doing it for the last 10 years, we do exactly, and this is where I couldn't agree more, we have our vascular board where we all come together, where we discuss the cases. And this also goes a little bit to the question before, Hakan. So for example, if you have a ruptured brainstem AVM or an unruptured, it totally depends, but if it's a ruptured one, and then most of the times for ruptured AVMs, there is emergency EVD put in. There's most of the times patients are on the ICU, and most of the times there is for brainstem AVMs no real microsurgical option, but then our hybrid, because our vascular surgeons are hybrid vascular surgeons, so they do the surgery and the endovascular treatment, both of it. So most of them go for embolization, and if this does not totally obliterate the AVM, then we do multimodal treatment and we do gamma knife radiosurgery for the residual nidus. However, for the last 5 years now, I can recall at least 10 cases where from the beginning our hybrid vascular surgeons said that there is no good way to do an embolization. And the plan was that if the patient recovers from ICU, and then we did gamma knife radiosurgery up front. So I agree with Hakan as well. You have to do a tailored treatment plan, decided case-based.
Thank you. And I'll answer the questions of Dr. Barbara. One question was about the laser coagulation. Does it affect the underlying parenchyma? no, Dr. Marco showed very well that there was no problem about the parenchyma. And the second one, about the radiosurgery, she asks how we are doing. Actually, we are only defining the nidus and irradiating the nidus, not the feeders. We are trying to keep away from the vein.
Exactly, yeah. So we targeted the nidus, and you actually have to leave out the draining veins, at least from the hot spots, because if you close the draining veins, that's like plugging a basin and then it overflows. So you actually have to find a way to target the nidus without attacking the draining veins early on, and you don't target the feeders.
And maybe this question can be answered by both Marco and Işıl. I don't know, how do you do it in endovascular, but do you apply any hemodynamic endpoint in terms of blood pressure targets during the procedures?
Marco?
No, well, after surgery, we keep the patient in the intensive care with the low pressure for at least 12 hours, at least until the morning after, because one of the main problem is that you have to close all the vessels and let them coagulate, and the extension of the coagulation has to be stable. So we try not to awake the patient immediately after surgery, but just leave him in. We do endovascular, we do angiography just to check if everything okay, and then keep the patient in the intensive care with the control of pressure without making him cough and going after surgery in a hypertension for a while. Then we wake it up. But after surgery, when he is awake, there is no need to control the pressure.
Regarding the embolization during the procedure, we always keep the patient's blood pressure low, like 60 or at most 70 systolic, and for transarterial. And I know for the transvenous embolization, they can even create asystole periods during the injection, so that they can reduce the risk of transvenous embolization. We do transvenous only in very selected cases, and we lower the blood pressure significantly, but we do not do asystole in our experience. After the occlusion cure of the AVM, as Marco already said, we keep the patient under low blood pressure, but not, that low, I would say, but at least keep the patient, under control, so that the blood pressure would not be higher than 100 millimetric curie mercury in systolic.
Thank you. And another question for Yosa. Do you apply re-gamma knife for not completely overtreated AVMs? Why? And what do you think about hypofractionated gamma knife for AVMs?
So to the first question, yes, we do. As I mentioned in our retrospective series, we had 31%, roughly a third of patients who actually had multiple gamma knife treatments. And 2/3 of those were actually due to not immediately obliterated AVMs, and another third of those were truly volume stage cases. So which answers actually the second question. Hypofractionation, yes, but not dose stage. I don't believe into dose stage, meaning to hypofractionate in regards of the doses, like a radiotherapy fractionated dose regime, but I believe in volume stage. So I've been doing, especially for the very big or large AVMs, I have started to do volume stage, and it actually works very well. For the multiple gamma knife, after not truly volume stage cases, yes, I do that, and this is most of the times if you have a like medium to larger sized AVM, and then I start with the first blush of the angiography of the nidus, and then I apply a very conservative approach, because I don't want to have the patient to actually get new neurological symptoms. So I don't cover too much of like the total nidus, and then it shrinks very nicely most of the times. And then if there is a small residual nidus, then you do that as a second treatment, and that actually works very well. Of course, you can say now that prolongs the time for the patient until obliteration, but among those cases, we have a very, very low rate of complications and a very, very low rate of new neurological deficits. So for us, that more or less conservative approach actually worked very well so far.
For all speakers, do we apply anti-angiogenesis medication strategies like anti-VEGF and others? And what is the ideal combination? Actually, ideal combination is something different, case by case. Again, I will give the same answer, but do we apply VEGF for the other ones?
We don't.
We don't.
We do.
It's not a proven treatment for the AVMs.
Not yet.
Not yet. And is partial embolization more prone to recanalize?
Yes, depending on what you are doing in your embolization. If you are doing pedicle embolization, I mean, in ours, we do while we are targeting the cure, this is something different. But if you do as a partial embolization, feeder embolization, then you make things even worse because of the collaterals supplying the AVM are worse than the original vessels, and they are more difficult to control, I'm sure, from the perspective of surgery, and also for the embolization as well, for the following proceeding embolization as well. So partial embolization makes the AVM worse if you left like that, if you do just pedicle embolization. Regarding the recanalization, if you do not occlude the vein, it's going to come back. So whether you think you have complete obliteration or not, if it's partial or, so to say, total embolization, if you do not occlude the nidus with the vein, then it's going to come back. And in the kids, there may be regrowth in the very long follow-up. Despite that first 10 years, you do not see any, I don't know what to call, whether to call it recanalization or regrowth, because for 5-10 years, you may not see any recruitment, but after a certain time, when you treat it during the childhood, they may come back despite that you think you cured. There are 1 or 2 cases like that, and I am aware of other people's experience in that regard too.
You know, if I may say, when we treat 2 things. When we treat a pediatric AVM, we propose a follow-up until at least at 25 years of age. There is a paper from Lancino that say that in a pediatric AVM, you have a 14% of regrowth, so very high number. And so it's very important to check over time, at least for at least until the 25 years of age. What you mentioned about the vein is valid also for surgery, because if in the post-op angio we see a vein, we go back in the OR, because having a vein in the precuous vein in the post-op angiography means that the AVM is not cured. So you have to don't see the vein after the treatment.
Actually, what I am saying is not only, I mean, if you are seeing a vein post-operatively or post-embo, then it is not cured. I'm not talking about that. I mean, this is for sure, 100%. But what I'm saying is, even though you do not see any vein in the post-operative angio, but in your postoperative sectional imaging, the Dyna CT, that you did not take the vein. You stayed in the nidus, even though the vein does not fill postoperatively, it may recur. That's what I'm saying. I mean, if it is filling from the beginning in the postoperative, then it is not cured anyway.
Yeah.
So coming to
Exactly.
the end, I'll just make some conclusions. Dr. Saatchi mentioned that make a really good statement that I can always use. Embolization must serve for a purpose. Every treatment serve for a purpose, But for embolization, which I am a good witness for this, if you make it compact embolization, if it's really volume reducing, then radiosurgery really affects and you can get good results. But if you make embolization in a patchwork style, don't do it. We have to do it in a compact way. And about Yosa, as she mentioned well, if you select good cases, radiosurgery is really safe and it's mostly better than only observation. And for grade 3 AVMs, radiosurgery is definitely in good position, or maybe the first option, And about 30, as the Marco mentioned well, we should work with a definite plan. We should decide well, we should analyze the vascular architecture and start the treatment. We must have a definite plan. And about Aruba, I think we have to thank to Aruba, because before Aruba, the studies about AVM, the rate of publications about AVM was lower than after Aruba. After Aruba, the increase is really unbelievable about the AVM studies. And these three methods are not, I think, in competition. They are, we have to combine them in really selected cases. We need experienced teams, and we need to discuss case by case. And I have to thank to Piero and all speakers and all participants. Thank you.
Thank you very
Thank
much
you.
to all of you for the presenters, Marco, Isil, and Yosa, and thanks to Hakan for the terrific effort he made to organize this webinar. Thank you to all of you, and see you soon.
Thank you.
Thank
Bye-bye.
you. Thank you all.
Bye-bye.
Thank you. Bye.